So the last 4 weeks we have been discussing vertical systems. So we talked about the autonomic nervous system and the somatosensory system and the motor system and some other things having to do with motor. So now for the rest of the quarter we are going to start talking about regions. So the first region we're going to talk about is the peripheral region. So we had talked before where there's the central nervous system and the peripheral nervous system, and the central nervous system includes everything that's encased in bone. So the peripheral nervous system includes all neural structures that are distal to the spinal nerves, including the axons of cranial nerves that are outside the skull. We'll talk about cranial nerves in chapter 19. You can sort of think of cranial nerves as being the peripheral nervous system for the head, if you want to think of it that way. The axons of sensory, motor, and autonomic neurons are included in the peripheral region, including the specialized sensory endings and the postganglionic autonomic neurons. All of those together form the peripheral nervous system. So our learning objectives for this part of the PowerPoint, there are 2 PowerPoints for chapter 17. The learning objectives are you should be able to define endoneurium, perineurium, epineurium, and fascicles. Pretty easy. And I want you to be able to list the 4 major nerve plexes and which part of the body they innervate. So if I said, if I gave you a body part like the foot, you would be able to tell me which nerve plexus innervates the foot. Okay? So, like I was saying just a minute ago, the peripheral nervous system includes all neural structures distal to the spinal nerves, including axons of sensory, motor, and autonomic neurons, specialized sensory endings, and postganglionic autonomic neurons. All the nervous systems enclosed by bone are considered the central nervous system. So, nerve roots, dorsal root ganglia, and spinal nerves are within the spinal region, which we'll talk about in chapter 18. So in this diagram, this figure from the book, there's a dotted line right in the middle here that you can see, and everything to the left of the dotted line in this picture is peripheral nervous system. Everything to the right is central nervous system. So just to kind of give you a visual. The neural structures in the periphery include muscle spindle receptors, Golgi tendon organs, motor endings in muscle, and axons. We'll talk about in the spinal region the different divisions of the spinal nerves, but basically the posterior rami, ramus means arm, just like it did when we were talking about the pelvis in kinesiology. So the posterior arm of the spinal nerve innervates structures along the posterior midline of the body. And the anterior supplies structures in the lateral and anterior body. So we'll talk more. Okay, so the peripheral nerves themselves consist of parallel bundles of axons surrounded by 3 connective tissue sheaths. So when we talk about a peripheral nerve, we've talked about these before. So, femoral nerve, sciatic nerve, obturator nerve, all those ones that we talked about in kinesiology. Each one of those nerves is a bundle of axons. It's parallel bundles of axons. So those axons could be somatosensory axons, they could be motor axons, they could be autonomic axons. So the nerve itself is a combination of all those different types of axons. So the endoneurium separates individual axons. So each axon is surrounded by endoneurium. The perineurium surrounds a fascicle, and a fascicle is a bundle of axons. And then the epineurium encloses the entire nerve trunk. So the endoneurium, perineurium, and epineurium are all connective tissue, and they are all surrounding. So remember when we talked about this in muscle, we had the endomysium and the perimysium and the epimysium. very similar terms, very similar arrangement of the bundles. So the picture on the left here, I really like this picture. It's an electron micrograph of a nerve. And when they're doing pictures of nerves like this, they do a stain that stains myelin, so anything dark is myelinated. So you can see all those individual little neurons, all those individual little axons that are myelinated running in those bundles, which is pretty cool, actually, that you can see it like that. So when you look at pictures in the book and pictures in other sources that are stained like this, the myelin is the dark part, and we will see more pictures like this. So just very similar to the muscle terminology, the individual axon is surrounded by endoneurium, the fascicles, bundles of axons, are surrounded by perineurium, and the entire nerve trunk is surrounded by epineurium. So peripheral nerves supply either the viscera or somatic structures. Somatic peripheral nerves are usually mixed, including sensory, autonomic, and motor axons. Cutaneous branches supply the skin and subcutaneous tissues. Muscular branches supply the muscles, tendons, and joints. That includes those Golgi tendon organs and joint capsule nerve endings. Peripheral axons are classified according to the speed of conduction and the diameter. Remember, we talked about this in chapter 10. So all those different axon classifications still apply, whether it's sensory or motor. So there are, as the spinal nerve roots exit the spinal cord, the anterior rami join together to form 4 nerve plexuses, or plexes is actually the correct plural. Plexuses is sort of the new version, but either one is correct. I'm hung up on the old version, so I'll say plexes. But cervical, brachial, lumbar, and sacral are the 4 plexes. So the different extremities are innervated by the different plexes. So you can think of the really in general, and we'll talk about this more specifically, but the cervical plexus is sort of the head, brachial plexus is the arms, and the lumbar and sacral plexus is the legs. So pretty simple in terms of that, but we'll talk about it more specifically when we talk about each one. This is a diagram of the lumbosacral plexus, so the lumbar and the sacral combined, which is kind of a neat diagram. I like it. The cervical plexus provides cutaneous sensory information from the posterior scalp to the clavicle. And it innervates the anterior neck muscles and the diaphragm. Okay, pretty important plexus, right? Because it innervates the diaphragm. If we don't have that innervation, we can't breathe. So we'll talk about this a little bit more in the spinal region. But a good way to remember which level of the cervical spine innervates the diaphragm, it's C4, breathe no more. So if you have a spinal cord injury above C4, then you will need artificial respiration in order to breathe. So I think that's all we need to say about that right now. We will talk about it more later. In chapter 19, we're going to talk about the cranial nerves very briefly. We're not going to go into serious detail. But the cranial nerves, you can sort of think of them as the peripheral system for the head and face. So the brachial plexus innervates the entire upper limb. So remember in kinesiology when we talked about the brachial plexus and the different nerves coming off of the brachial plexus and the different divisions of the brachial plexus? Well, here it is again. So you will need to know this information for your upper extremity orthopedics class because you'll be talking about different nerve injuries, different weaknesses coming from nerve injuries, different treatments. And we'll talk a little bit, in the module there's a section about nerve tension neurodynamic exercises with videos for each one, and the assignment this week has to do with neurodynamics. And so when we're talking about the arm, of course, we're talking about nerves coming off of the brachial plexus. The lumbar plexus, the branches innervate the skin and muscles of the anterior and medial thigh. So you'll see sort of at the bottom of this diagram, the two peripheral nerves sort of coming off of the lumbar plexus are the obturator and femoral nerve. And remember when we talked about the muscles in kinesiology, the obturator is sort of the inner medial thigh, and the femoral is the anterior thigh. So if somebody asked you an exam question, I don't know who that person would be, but if somebody asked you an exam question, which one of these is innervated by the lumbar plexus, and one of the choices was anterior and medial thigh, that's what you would pick. Okay, so that's the kind of question you can expect to hear from about nerve plexes. The sacral plexus innervates the posterior thigh and most of the leg and foot. So everything but the anterior and medial thigh, really. And it also contains parasympathetic axons. Because remember, way back in the autonomic chapter, the sympathetic trunk was the thoracic outflow, and the parasympathetic was the craniosacral outflow. So here's the sacral part of that. So of course, you know, the big nerve coming off the sacral plexus is the sciatic nerve, which then splits into the tibial and common peroneal or common fibular. So that innervates the posterior thigh and most of the leg and foot. So if I said, hey, what your lower leg, which plexus innervates that, you would know would be the sacral plexus. So movement optimizes the health of nerves by promoting blood flow through the nerves and the flow of axoplasm through the axons. So if you don't have any movement, the axoplasm will sort of thicken up, and you won't have as good a flow. You won't have that axoplasmic transport from the soma to the axon terminal will not work as well if the axoplasm is thicker. So movement of the nerves causes the axoplasm to thin and flow more easily. So when the axoplasm thickens because of immobility, it becomes more resistant to flow. So this is a picture of nerve fibers when the muscle's in a resting position, or when the limb is in a resting position, and they sort of fold in on themselves and crumple a little bit, which is kind of cool that they do that. So really our bodies are supposed to move, so the nerves have to move as well. The connective tissues that surround the nerves, the endoneurium and the perineurium and the epineurium, they support the changes in length that the nerves undergo during movements. So if you abduct your shoulder to 90 degrees, the median nerve is approximately 10 centimeters longer when the elbow and wrist are extended than when the elbow and wrist are flexed. So this increase in nerve length without injury is made possible by this sort of wrinkling effect within the endoneurium when the nerve isn't stretched. So we have to have that play. So it's almost like when the nerve isn't on stretch, we have a little bit of slack in it, and that allows us to make the movement. If the nerves were super tight, we wouldn't be able to move without pain. So when you stretch the nerve, you get a little bit of unfolding, and the fascicles glide a little bit relative to one another. And as the stretching continues, the entire nerve slides relative to surrounding structures. So if you continue to move past that, then you develop tensile stress within the neural tissues. And as the nerves shorten, the process reverses. The tensile stress is relieved, then the nerve slides relative to the surrounding structures, then the connective tissue recoils, and the axons fold. So the nerve can also fold. At the elbow, the median nerve folds, and this allows us to lengthen and shorten without injury to axons or the supporting structures. So that's pretty cool. We have this sort of built-in slack in the nerves in order to be able to move. So in the module, there are videos of nerve tension exercises, basically. Neurodynamic exercises. So nerve glides is another name for them. And this is a really helpful, particularly if you're working in an orthopedic setting, it's a really helpful tool. A lot of times people with injuries, because the nerves are supposed to slide in the connective tissue sheaths, if you have an injury, if you have scar tissue, the nerves don't slide as well, and you might get paresthesias or other nerve type symptoms distal to the lesion. So by doing these nerve glides, we actually help free up the connective tissue and help decrease those neural symptoms with movement. So in the module, you'll see those videos for different neurodynamic exercises, and then the assignment today is the assignment this week is to identify different positions that might cause nerve stretching or nerve tension. And then what sort of treatments you might do to alleviate that. So the motor axons, of course, synapse with muscle fibers at the neuromuscular junction. And nerve muscle synapses, they're always excitatory. So in a neuron-neuron synapse, you need summation of action in order to depolarize the postsynaptic membrane. In a motor unit, every depolarization of the motor axon releases enough acetylcholine to initiate action potentials in the innervated muscle fibers. So we want the neuromuscular junction always to be excitatory because we always want the muscles to contract when they get a signal. So that's really the neuromuscular junction. Its job is to be excitatory. And when it doesn't, that's when you get into issues. And we'll talk about that in the next section.